Hello, everybody. This is my first time trying this recording call. I'm going to try doing the restraints PowerPoint here so that those of you that missed it at the meeting can still get all the same stuff that everybody did. So I'm going to share my screen here so that you can see the PowerPoint. And all right, so we'll go through our PowerPoint here. This is the same PowerPoint that you get every year. Nothing has changed, but it is an annual competency that we go through. It's especially important right now with kind of what we've been seeing in the news and appropriate restraint usage, that kind of thing. So I do want you to pay attention to all this content here. At Mercy, we know our patients have rights and responsibilities. They get a pamphlet of this when they are admitted to the hospital, and we need to be aware of them just as well. So at Mercy, patients have the right to be free from physical or mental abuse and corporal punishment. They have the right to be free from restraint or seclusion of any form when it is imposed as a means of coercion, discipline, convenience, or retaliation by staff. Safe implementation of restraint usage or seclusion by trained staff, and to receive care in a safe setting. This is our restraint policy procedure. It is found on the portal, just like all of our other policies. Our use of restraint and seclusion are only employed when it's clinically justified by a parent's behavior, not by a particular diagnosis. If their behavior threatens the physical safety of themselves, the staff, or anybody else, that is when it is clinically justified. We use restraints in the ER, and any hospital locations that use them might include ICU and behavioral as well. So what is the definition of a restraint for Mercy's policy? It's any manual method, physical or mechanical device, material or equipment that immobilizes or reduces the ability of a patient to move his or her arms, legs, or body, or head freely. We use several different types of restraints here at Mercy. Some you'll see a lot more frequently than others. We do have those freedom splints, which you'll see in that top right picture there. Very rarely used, but it can be effective, especially for somebody who maybe has dementia and is pulling at those lines, drains, and airways. Our soft mittens, they are restraint only if they're attached to the bed, if they're tied down, which we'll talk about in a little bit as well. Our soft tie extremity, those posy restraints, those are a non-violent restraint. We see those often used with intubated patients. Our Velcro restraints are our violent restraints. This is probably what we're most familiar with in the ER setting. Safety enclosure beds, not really seen used anymore, but they do exist. And then physical holds, of course, we do use, but they should be documented as such as a restraint. Things that are not restraints, if the patient's able to remove it in the same manner that it was applied. Law enforcement restraints, they are not restraints per Mercy's policy. If they come in law enforcement restraints and the law officer does not want them removed, such as like wrist shackles, leg shackles, then we need to document that, but the person that put them on and who has the means to take them off needs to remain at bedside 100% of the time, and that needs to be documented. We do not have the means to take off those restraints, and we were not initiating those restraints. Also, spit socks we do use a lot in the emergency department. It is not necessarily a restraint, and I also like to point out that it prevents getting spit on, but it does not prevent biting. Other things that are not restraints, mechanical supports like leg braces, orthopedic devices, positioning or securing devices like OR tables, procedure tables, or chairs, anything that's age or developmentally protective devices, and recovery from anesthesia in PACU or ICU. Equipment that's not considered a restraint, IV arm boards, that is used for the optimal function of an IV, not with the intent of restraining somebody. A jerry chair, as long as it doesn't have the locked tray on it. A cart or bed with the side rails. Not usually an issue for us at the ER. That's just because we only have 2 side rails, and that's a safety mechanism with a transport bed. However, upstairs they have 4 side rails, and that is considered a restraint if they have all 4 of them up. You can have 3, just not 4. So both side rails in the ED is okay. It is a transport bed, and that's a safety mechanism. Hand mittens, if you do not tie them down, they are not considered restraints, so they can be a good distractor as well. Anytime we're using restraints, we need to be trying alternatives before we get to that point. There is a section in our documentation under safety. I believe I have a screenshot of it here in just a little bit, that you can document least restrictive environment, things that you've tried to avoid using restraints. Here's a few ideas here: activities of interest, lights, dimming them, making them relaxed, reoriented, having family or friends at bedside if that's possible, helping them to the bathroom, ambulating them, exercising, all of those. Our restraint orders, when a physician puts in a restraint order, they have to put in what type of restraint that they want used, where we're using that restraint anatomically, and why are we initiating that restraint. This can get a little confusing, and we as nurses and paramedics need to be watching out and making sure that the type of restraint they order matches the reasoning for that order. So if you're using soft tie posies, that's only a non-violent restraint. So they need to make sure and order it as non-violent. I have had in the past a physician order a violent restraint and then have in the documentation that they wanted soft tie posies. Well, that doesn't match. I had to go back to that physician and say, do you want violent or do you want non-violent? It's all in your intent, but the type of restraint that's documented or ordered needs to match what we're actually using and which flow sheet we're documenting under. Our timing to obtain orders. For non-violent restraints, you have to have an order before you apply the restraints. Usually we have more time with those, but you only need a order once per occurrence. Once you document that you discontinued that restraint, you will need a new order to put it back on, but otherwise that order is good for the whole duration that those restraints are on. Violent restraints, however, are Velcro restraints. We can apply those without an order, but you need to get an order within a few minutes after the application. The order duration is dependent on the age of the patient. So if it's an adult, 18 or older, the violent restraint order is good for 4 hours. If they are 9 to 17 years old, it is good for 2 hours. And if they are under 9 years old, it is good for only 1 hour. This has been occurring more frequently than we had seen in the past. So we do actually have, I can get out of here and show you the pediatric restraint guideline. Here so you can see it. This should be familiar to you. It is not new this year, but in EPIC, you'll see the names change colors if they have a restraint applied in their pediatric patient, and then as it approaches the time of the duration that the order is about to expire. So you'll see the 9 to 17 years old, as it gets 20 minutes until the order expires, the name will turn orange, and 5 minutes until it'll turn lime green. Once you turn pink, it means you are past the time. We don't get 2 minutes past, we don't get 30 seconds past. We have to have a new order before that expires, or we need to have the restraints off. This is posted in the nurses station also. We don't have these colors memorized. And back to our PowerPoint here. So in order to apply restraints safely, we need to consider the patient's history. We need to pad any bony prominences. We shouldn't be putting restraints above an IV site. We need to secure them to a part of the bed that is not movable. This is actually pretty challenging with our violent restraints, just because the beds don't have places that they can reach very easily. Oftentimes I am having to restrain people with one arm up and one arm down. Just be really careful of the movement of their joints as well. And we do not hook them to the side rails, because those maintaining good body alignment, comfort, and safety, and making sure that the restraint is not too tight. We need to leave at least 2 finger widths in between the restraint and their wrist. Here is the document that I share that shows you how to tie restraint. If you're watching this because you missed our staff meetings this year in June, then you will meet with me to tie a restraint after you've viewed the content here as well. Our assessment and monitoring, our documentation looks a little bit different. This is the inpatient. The biggest thing I want to touch on for documentation for us in the ER is that you flow sheet that you choose needs to match what type of restraint you're using and the type of restraint that's ordered. So if you're using a soft typosy restraint, the physician needs to have ordered a nonviolent restraint, and you need to document under the nonviolent flow sheet. Likewise, if they order a violent restraint, we should be using Velcro restraints, and we should be documenting under the violent restraint flow sheet. Nonviolent restraints or soft typosies are typically used in the ICU. Our documentation and assessment needs to occur at the very least every 4 hours. We're in the patient room usually a lot more frequently than that, so by all means, document more frequently. The orders to initiate, continue, and discontinue. You only have to get one order per occurrence, but you have to get it before you initiate them. If they're removed for any reason other than patient care, so temporarily released for ADLs, then the order must be discontinued. And then if you need to reinitiate the restraints, a new order must be received. I do have here a soft typosy restraint, just to refresh your memory on what these look like. And our violent restraints over here look like this here. This should ring a bell. We use these pretty frequently. They are Velcro. The soft padded side goes against the patient's wrist, and the non-padded side is what you attach to an immovable part of the bed, as you'll see here. It does say here, and the way that I remember it, we do have two different colors of restraints, the red restraint and the blue restraint. Someone once told me, and this stuck with me, that the sky is blue and the sky is up, so the blue restraints are up, they're the wrist restraints, and the red are the ankle restraints. And it took me back to the beginning here, so let me get to where we were. Our violent restraints typically were used in the behavioral unit, in the ED and ICU. Our assessment and monitoring on that is every 30 minutes, and if a patient's in violent restraints, they need to be a one-on-one. We need to have continuous visual observation of that patient. The orders to initiate, continue, and discontinue, again, are dependent on the patient's age. This is very important, which is why it's repeated here. If they are 18 or older, the restraints order is good for 4 hours for violent restraints. If they are 9 to 17 years old, it is good for 2 hours. And if they are under 9 years old, the order is good for 1 hour. A physician must perform a face-to-face evaluation within an hour of ordering the restraints. Not usually a problem in the ER because our physicians are right here. And then also if they're on the unit, they need to have another face-to-face evaluation after 24 hours. I'd mentioned this earlier, if you temporarily release the restraints for any kind of ADLs, range of motion, bathing, bathrooming, etc., that is not a discontinuation. If you document a discontinuation and say that word, you need a new order to put them back on. If you are taking them off temporarily, you need to stay with that patient 100% of the time and maintain that continuous visual observation. Family sitting with the patient does not count, even for pediatric patients. We need to discontinue restraints as soon as possible. As soon as that behavior condition that got them into restraints has resolved, we need to discontinue them. In EPIC, you have to actually go in and discontinue the order for the non-violent restraints or the soft typosies because they aren't just going to fall off. The order for violent restraints will automatically expire, but if you are taking them off before the duration is done, you should just go in and discontinue it anyway to show that endpoint. One thing we talked about that came up last year was discontinuing your restraints one limb at a time. We do not do a trial of discontinuation, but we can release the restraints one limb at a time. However, if you do so, the physician's order needs to specifically state that that is okay, and all 4 restraints have to be off by the end of that order duration. I hope that makes sense. So if your order is coming up as expiring here, it's been 3 hours and 45 minutes, and you're going to discontinue the restraints. If the physician said we can put one limb at a time, all 4 of those have to be off by 4 o'clock. Death reporting. If somebody dies while they're in restraints or seclusion, specifically violent restraints, or within 24 hours of being in restraints or seclusion, we need to report this to CMS. Also, if they die within 1 week after restraints or seclusion, if it could have possibly, their death could have been linked back to the restraints or the seclusion. And this should be documented in the medical record. If they die in non-violent restraints, that's not actually unusual, because we do have a lot of patients that are intubated in restraints. We don't have to report this to CMS, or if they expired within 24 hours of non-violent use. However, we do keep a log just in case. Chemical restraint. I sure hope you've heard this before. The use of a medication to restrict the patient's freedom of movement that is not a standard treatment for the patient's new or continuing medical or behavioral condition. We do not use chemical restraints at Mercy. The difference is your intent. So we do use medications that are standard treatment for a particular patient condition. We give them in appropriate doses for the condition. We don't give them with the intent to know them so they're easier to deal with. There are a few medications that ride that fine gray line: sleeping medications, anti-anxiety medications, antipsychotics, or pain medication. Seclusion. It's the involuntary confinement of a patient alone in a room or area from which the patient is physically prevented from leaving. It can only be used for the management of violent or self-destructive behavior, and it is only used on the behavioral health unit. We do not use this in the ER. And I say this time and time again, kind of like those McDonald's cups that have the warning, this is hot on them. This is on here for some reason, but timeout is not considered a seclusion. Complications of restraint use. This is very important given what we've seen in the news lately, and we need to safely care for our patients. That is one of their rights. We need to consider some complications of restraint use. Specifically, positional asphyxia, choking, patients that might be at higher risk, people who are obese, people who are intoxicated, people who are exhausted or in that prone positioning. Warning signs. If they complain or say that they're unable to breathe, you need to take that very seriously. If you see the patient feeling sick or vomiting, if you see swelling, redness to their face or neck vein distension, if you see changes in their behavior or their level of consciousness, if they become limp or unresponsive, or if they go into respiratory or cardiac arrest. All of these need to be taken very seriously. There are some more emotional and physical complications of restraint use. Consider what you're doing to the patient, and imagine putting yourself in that position. It's very degrading, lost complete control. You're going to become agitated, angry, depressed. You're going to feel embarrassed, be very scared, and you're going to have feelings that you're being punished. More long-term use, physical complications can include things like pressure ulcers, decreased muscle tone, infections, nerve injuries, bruises, fractures, strangulation, constipation, incontinence, and thrombosis. Now, we are all nurses, so I don't feel that we need to go horribly in depth in the first aid, but if somebody does get injured, please make sure and take care of them. Common areas of injuries that can be related to restraints: head, neck, or spine, bruising, bleeding, cuts, scrapes, fractures, and sprains. All right, so that's the end of our PowerPoint here. And if you are watching this, then I will need to meet with you or one of the shift supervisors, and we can take a look at you tying one of the soft tie posy restraints as part of this competency as well. So thanks for listening. I hope this went well, because like I said, this is my very first time doing this. All right, I'll talk to you later. Thanks, bye.